Hello everyone. Today we'll discuss about laboratory investigations of congenital infections. So in congenital infection, everybody knows it is torch infection. T stand for toxoplasmosis, O stand for other infections, R for rubella, C for CMV and H for herpes. And you have other infections also, that is E, it stands for enterovirus, and S stands for syphilis. Okay, these are the other two infections. Supposing if they ask in your viva session or in your theory examination question, you have to write these two. Okay, so today in this video we'll discuss about toxoplasmosis, rubella, CMV and herpes. So starting off with the congenital toxoplasmosis, first is maternal investigation. So we have to screen the mother whether she have acquired the infection during the current pregnancy or in the past. So for that, first investigation is you do serological investigation, that is you do serum, IgG and IgM. This serum, IgG and IgM, if it is performed in an earlier part of the pregnancy, that is during the first trimester. So if this is performed, this investigation during the first trimester, this is more helpful in determining the infection. Okay, next, so after you do this investigation, how do you interpret the result? If the patient is having IgG as positive and IgM as negative, then it is indicative of prior infection, that is it excludes the infection during the current pregnancy. So this excludes the infection during the current pregnancy. Okay, next, if the patient is having IgG as positive and IgM as positive or equivocal, okay, then you should confirm this. You should confirm this by in a reference lab. It should be confirmed in a reference lab. Why in a reference lab is because they help to differentiate between a recent infection and a distant past infection. So they help to determine. So they help to determine if the infection has been acquired in recent, that is during the current pregnancy, or during a past. Okay, next, second investigation is differential agglutination. Okay, in differential agglutination you have AC and HS test. So what does this AC and HS stands for? So this AC stands for acetone fixed tachyzoids. So this tachyzoids comes in the life cycle of our toxoplasmosis. Okay, and HS stands for formalin fixed tachyzoids. So how do you interpret their results? If the mother is having a recent infection, that is infection during the current pregnancy, both the AC and HS will agglutinate. So if the mother has a recent infection, both AC and HS will agglutinate. Next, if suppose the infection has been acquired in a past, but not during the current pregnancy, then HS, that is formalin fixed tachyzoids, will agglutinate more than this acetone fixed tachyzoids. This is how you differentiate or interpret the differential agglutination test. Next, how do you do the investigation or screen the fetus? So it is by using a monthly USG, monthly ultrasound you do to the mother. Next, PCR of the amniotic fluid. Okay, So PCR of the amniotic fluid will give you a correct result or a diagnostic result for the congenital toxoplasmosis. What is the optimal time for doing PCR of amniotic fluid? It is more than 18 weeks of gestation. This will be the optimal time for doing the testing PCR of amniotic fluid. Next, how do you screen the neonates? In neonates, it is also you do a serological investigation. First, you do serological investigation. In serology, you do IgG, IgM, and IgA. Okay. So first, we'll talk about IgG. So this IgG, it will appear within 1 to 2 weeks of infection. So this will appear within 1 to 2 weeks of infection, and it will peak at 1 to 2 months. Okay, and it will persist throughout the life. Supposing if the infection has been acquired through a transplacental route, so a transplacental IgG antibody will disappear by 6 to 12 months of age. So a transplacental IgG antibody, this will disappear by 6 to 12 months. So this will disappear by 6 to 12 months of age. So transplacental IgG antibody will disappear by 6 to 12 months of age in the neonate. Supposing if the neonate continues to show a positive IgG titer at 12 months of age. So when the neonate is having a positive IgG at 12 months, this is confirmatory for a diagnostic congenital toxoplasmosis. This is a diagnostic of congenital toxoplasmosis, that is the neonate is having a congenital toxoplasmosis. Okay. Next, if suppose the neonate has a positive IgM or IgA antibody at 10th day. Okay, this is a 10th day, that is 10 days after the birth. It is also diagnostic that the neonate is having a congenital toxoplasmosis. Understood? So this is about laboratory investigations of congenital toxoplasmosis. First investigation. The next investigation, the second one, first is serology, next is PCR. That is molecular testing of blood, samples like blood, urine, CSF should be performed for all infants with the suspected infection. So PCR, that is molecular testing of this blood, urine and CSF is performed. So this is performed for all infants with suspected congenital toxoplasmosis infection. Okay, so this is about congenital toxoplasmosis. Next, we'll see about congenital rubella. So in congenital rubella, you have antenatal diagnosis and postnatal diagnosis. In antenatal, first you do a specific IgM in the fetal blood. How do you do in a fetal blood? It is through a percutaneous umbilical cord sampling. It is done through percutaneous umbilical cord sampling. So specific IgM for rubella infection through the umbilical cord sampling, it should be done. Next, second investigation is direct detection of, it is a direct detection of rubella antigen and RNA through chorionic villus sampling. So these are the two ways by you do a antenatal diagnosis. Next, in postnatal, you can do is made by either one of the following from the below. Okay, first is you do a isolation or detection of rubella virus in samples like, you take the samples in such as oropharynx and urine. You take these two samples and you isolate or detect the rubella virus. This is mostly done in a specific culture, that is rubella specific culture it is done. Next, second, detection of rubella specific IgM. So detection of rubella specific IgM in neonatal blood within first 6 months of life. This is also specific or diagnostic for this rubella infection, congenital rubella infection. So these are the 4 investigations. So in antenatal you have 2. One is specific IgM in fetal blood. Another one is direct detection of rubella antigen and RNA through chorionic villus sampling. In postnatal you do isolation and detection of rubella virus through the oropharynx sample or a urine sample. Next, detection of rubella specific IgM in neonatal blood within first 6 months of life. Okay. Next is congenital CMV infection, that is cytomegalovirus. That is, CMV shedding in urine and saliva has a highest sensitivity. So, cytomegalovirus shedding in urine and saliva, these both has highest sensitivity. Okay. So this should be when you suspect a congenital cytomegalovirus infection in a fetus or in a neonate, it should be suspected if the neonate have a typical symptom of infection. So suspicion. So when do you suspect? When the neonate has a typical symptom of infection or maternal history of febrile illness, or when there is a maternal history of febrile illness during the pregnancy, or when there is a USG findings, or when the USG findings are consistent with CMV infection. So what are the USG findings that are consistent with CMV infections? These will be, one is, that is when they have a echogenic bowel. Second, when they have a intracranial calcification. So these are the 2 USG findings that is consistent with the CMV infections. Okay. So these are the suspicion when you have to do a laboratory investigation for the child for CMV infection. Okay. First you do CMV PCR. So CMV PCR, this is a highly sensitive one. If the CMV is identified in an amniotic fluid or a urine, saliva, blood or respiratory secretion of an infant within first 3 weeks of life. So when this CMV PCR or CMV is identified in amniotic fluid, urine or saliva, or in respiratory secretions, or in the blood within first 3 months. Okay. So when they are identified within first 3 months of life, then it is said to be the child having congenital CMV infection. And the child is said to have congenital CMV infection. Supposing if they find that positive of CMV after within 3 weeks, 3 months, within 3 weeks of life. Suppose if they found to have a CMV at 4th week, it is the CMV PCR is negative for the first 3 weeks, but it is found to be positive at 4th week of life, then the child is having a peripartum or a postnatal infection. So I'll write it here, peripartum or postnatal CMV infection, that is if CMV is positive or detected after 4 weeks of life. Okay. Next, the serological test. And write it here. Second, the serological tests are IgG titer. Okay. So when this IgG titer is if negative in both mother and in the infant, then you exclude CMV infection. So if it is negative in both mother and in the infant, then you exclude CMV infection. Okay. And uninfected infants show a decline in the IgG titer by 1 month of age. Okay, but an infected infant will continue to produce IgG antibody. So this is a specific one. The titer will increase when the child has a CMV infection, or the titer will decrease by 1 month, and it will be negative in 4 to 12 months if the child does not have a CMV infection. So this is the serological investigation. Next we'll go on to congenital herpes. So in congenital herpes, what are the investigations you do? One is viral isolation or PCR detection of viral DNA. Okay. So viral isolation or PCR detection of viral DNA in a child with suspected herpes simplex virus, you will do these investigation. So how do you take sample? So samples are taken from, that is swabs from nasopharynx, conjunctiva and anus. So the swabs are taken from nasopharynx, conjunctiva and anus for viral isolation and PCR detection of viral DNA. Then you can also take samples from, if the child is found to have a CNS manifestation, then you take a CSF sample for HSV PCR. Next, scraping from skin vesicle. If the child is found to have this cutaneous manifestation, then you do a scraping from skin vesicle for HSV culture and PCR. So in viral isolation or a PCR detection of viral DNA, this culture of this herpes is said to be the gold standard for detection of the herpes infection. So these are the laboratory investigations for a congenital infection, when you suspect a child to have a congenital infection. Okay, thank you. In next video we will see for brain tumors, and we have brain tumors. Then in immunology we have approach to a child with an immunological manifestation, immunodeficiency. We'll cover all these topics.